Dr. Rahi Victory. I am your host for Fertility Factor Fiction. We always have quite a few laughs at the technical mumbo jumbo that goes on here, trying to get ready for the show. And tonight we are going to be talking about the ERA test, which I heard a lot about at the recent Canadian Fertility Show, and in discussion with one of my very well-known colleagues who has a very large social media presence, who believes that this works, and so I thought I'd take another look at it. And there was some new data that came out, which I thought was super interesting because it gives you a very clear perspective in a way that nobody had thought about it before. So this is important. And this is interesting because it's a relatively expensive test, and the value of the test is only if it actually increases the number of live births that we are anticipating. And so if it does, that's great. And if it doesn't, well, then the question would be, why are we using it? Huge shout out to the organizers of the Canadian Fertility Show and all the attendees and people displaying. My apologies to Dr. Marjorie Dixon, who was not able to attend, and they asked me to do her talk. So I hope I kind of did what you were hoping for. I guess there were some of her slides that had things like the N of a way, and I have no idea what the N of a way is, but I did my best with the info that was there. Oh, no volume? Uh-oh. I'm connected here. Can you hear anything? Hi, everybody. So apparently there's some trouble with the audio. I guess I don't need this thing then. No. So I can get rid of this itchy mic. Anyways, we are talking tonight about the ERA test and the fertility show that just went on in Toronto. So thank you to everyone that attended. Thank you to my nurse, Amy, and to Lisa, who organized everything for us, and everyone there. And I was just talking about the two talks that I gave. So one on all the adjuncts that we use in fertility, and one on some topics that Dr. Marjorie Dixon, who wasn't able to attend, wanted me to talk about. So I tried to do my best. Hopefully people learned from that, and it was a good experience. If you had some audio trouble before, is it good now? We are up and running now. Again, there's always some technical glitches we got to work the kinks out of. So it's a live show. It's a live show. We need screen mirroring. So tonight we're going to talk about ERA. And for those of you that are not familiar, the ERA is the endometrial receptivity array. So the idea behind this was that there were people who wanted to be able to determine if the window of implantation, the time of implantation when the embryo should be put in there, can be optimized. And so there was some data out of a group in Spain that are attached to IVI, the big IVF group in Spain, who said, yes, we have developed a chip. This chip tells you when exactly within 6 hours your optimized window is. Come and do our test. It's only, God knows how much, I think it was $750 at the time, just for their cost, and then we had to charge for all the stuff we were doing. And this will fix all your problems. Your failures are going to be resolved, blah, 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 blah. So we were all like, great. And I was a super early adopter, and I jumped right in and very quickly realized this test isn't doing anything. It doesn't seem to work at all, and it wasn't correcting our failures. So I started questioning them, and I definitely didn't get the answers that I wanted. So I basically stopped using it, with very, very, very rare exception. If you're a frequent viewer of our show, you'll know that I've mentioned before that we do use it when the endometrium is super thin, but you can't tell if it's receptive or not. So just to find if it's receptive or completely non-receptive, we do that test. So the reason this came up was I was discussing the topic with one of my online colleagues who's a very famous social media fertility person, and this individual said that they believed that it actually worked. And I said to myself, well, I'm not convinced that it works. Maybe I'm missing something. So I wanted to go back and look at the data again. So lo and behold, there have been additional studies I was not aware of because it wasn't in a fertility journal. And then there was a new article, which is as yet unpublished, which actually uses the data from the study I'm about to show you to show exactly whether or not the ERA test actually does anything. And so this is really, really important because I've actually been harping on the fact that it's useless for years, but I wanted to see for sure if what I was saying was right. And we've got some data, and you're going to find out if I need to change my mind or not. So we can screen share. Mm-hmm. Are we up and running? Mm-hmm. So this study is by Doyle et al. And it's called The Effect of Timing by Endometrial Receptivity Testing versus Standard Timing of Frozen Embryo Transfer on Live Birth in Patients Undergoing In Vitro Fertilization. So let's talk about the basic principles of this trial, because this is a very, very, very well done trial. Okay. Number one, randomized controlled trial. So half the group got the special timing of the ERA, and half the group just did standard day 5 embryo transfer, but everybody got the ERA test done. So in half the group, they ignored the result, they went ahead and transferred. And in half the group, they didn't ignore the result, they did what the ERA told them to do, go 10 hours earlier, later, whatever they told them to do. So very, very cool, because everybody got the same treatment, everybody got the same approach, but they divided it into two very clear groups. I had my ERA and I'm receptive, or sorry, not receptive, and they adjusted it based on whatever it was. And then I had my ERA and I ignored my results because it was important to just go ahead and see what it showed. So what did they end up finding out? Or sorry, which population did they use? They used women 30 to 40 years of age, so very reasonable IVF population, and every single patient that was included had genetically normal embryos. So this eliminates the potential of comparing apples and oranges because we know everybody had genetically normal embryos. And they excluded people that had recurrent pregnancy loss or recurrent failures. So this is a really nice tight population of healthy people undergoing IVF, genetically normal, high quality blastocysts. They were all BB or better, and they were all tested with the same test, but in half of them they ignored what the test did or showed and just went ahead and transferred with a standard protocol, and in the other half they actually followed what the recommendations from the ERA were. So let's have a look at a couple of the slides here. So this one's kind of important. I'll try and blow it up as much as possible. And for those of you, I won't show if I flip it sideways. It'll be too long. So for those of you on TikTok, I apologize you can't see this, but I'll be reading it out to you. So they had 1,887 candidates. 909 were not eligible because of various reasons. They ended up with 978. They had to exclude 187 because 115 didn't have embryos that were genetically normal. 39 had no blastocysts. 27, the patients decided to bail, and a few other reasons there. They ended up with 791. 24 more were excluded for various reasons, all of which were totally reasonable. Some people figured out whether or not they were going into the we followed the day 5 versus the we didn't follow the day 5 protocol. 4 had crappy thickness of their endometrium. 4 had repeat testing necessary to get their endometrial receptivity results. And obviously they weren't going to do it twice because that would cause unblinding. There were some with no results at all, and so on and so forth. So again, a really nice tight study. They were really very good with how they organized this and the information that they received. So you ended up with 767 people, 381 randomized to a receptivity timed frozen embryo transfer. In other words, what does it tell us to do from the ERA test? And 386 that were randomized to just a standard approach with no relevance to the ERA test. So 2 people withdrew from the ERA group, 2 people withdrew from the group with the non sort of ERA testing. Basically, 379 completed an embryo transfer in the ERA group and 384 in the standard group. A couple more people fell out after problems, but it was the same number in both groups. So 8 in one, 8 in the other. So again, it all is a wash. And you finally end up with 375 that got the ERA timed embryo transfer and 380 that got the non-ERA timed embryo transfer. Okay, so super quick here. The groups were all the same. There were no differences between the two groups. Everybody was happy with that. No significant issues. And then when they looked at the number of patients that were there, they ended up with the receptive being 44.6% in the ERA group and 46.1% in the standard group. Non-receptive, 55.4% and 53.9%. So keep in mind that this test is claiming that a huge number of patients undergoing embryo transfer were actually not receptive. Over half in each group was not receptive at the normal time and needed an adjustment. The majority are pre-receptive, meaning they need more time, usually 24 hours. 19% in each group were early receptive, meaning they needed a little bit shorter time of extra progesterone. And then there were some that were late receptive and some that were post-receptive, meaning that it had passed, but those were really small numbers. So the majority are in this group of being pre-receptive, meaning they need 24 more hours, or this early receptive, meaning they needed 12 hours longer. So again, interesting data, but concerning because it's suggesting that 50% of random people out there end up actually not being on time with their embryo transfer. So if the test actually worked, that would mean that we'd have a problem with 50% of our cycles, right? That makes perfect sense, and that 50% of people just wouldn't get pregnant because their timing is off. Considering our success rates right now, which are in excess of 85% with genetically normal embryos, that doesn't make a whole lot of sense for us. So here's the data, and I will flip this one sideways for you so that you will be happy. So in all the different categories, there was absolutely no statistically significant difference. Biochemical pregnancy, same. Biochemical pregnancy loss, same. Clinical pregnancy, same. Clinical pregnancy loss, same. Total pregnancy loss, same. Live birth, the holy grail, that's the one we're looking for, no difference. And if anything, it was on the side of actually the standard approach. So there were no differences, and they essentially said there is no difference in these outcomes. You get the same result if you follow the recommendation of the ERA that you did if you followed just the standard approach. They then had some subgroups that they tested, and in the subgroup analysis, they actually showed that there was a little bit of an increase in the biochemical pregnancy losses in the group that did the ERA, and there was a close to a trend in clinical pregnancy as well, showing that it was decreased in the ERA group. So now I want to show you this new study which actually explains why this is so important. So these authors, who are also in the States, reanalyzed the data from this study. So the original author said, look, it doesn't look like it works. If anything, it might be detrimental. It shouldn't be used anymore. So that's what that last study said. They basically said, nail in the coffin, ERA is over, right? It does not work. But these guys recognized one critical thing in this study that even the authors of that study didn't realize, and that's that they forgot to compare within the group that had the ERA test but didn't follow it, if there was a difference in the outcomes between those that were supposedly normal and those that were not normal. In other words, this is the real study we needed to do to determine if ERA works. Take everybody, find out which ones are receptive and which ones are not receptive. ignore the actual results completely, go ahead and do the same embryo transfer for everyone, and then compare the two groups. So everybody's being tested, but you ignored the results and you treated everyone the same, and find out if the group where the ERA said you're not receptive, whether you're pre-receptive or post-receptive or early, it didn't matter, is going to do better or worse than the group that in the ERA test within that standard treatment that was told that they had a normal receptivity. So just to make it super clear, my endometrial receptivity is normal, so I get the standard approach. And then Tarek's endometrial receptivity was not normal, but he also got the standard approach. If the endometrial receptivity array really works, then Tarek should do much worse than I do, because mine was normal, so a standard approach should work for me, but his wasn't, so it shouldn't work for him. He should have a lower success rate. So here's what happens when they do that study. So when they reanalyze the data, the first thing to notice, the live birth rates are actually really, really good, okay? So you take one genetically normal embryo, these guys are getting like a 63% live birth rate. So in this group, the standard timed transfer for people that were ERA receptive, so they had the ERA test, it showed that they were perfectly fine the way they were, but they ended up getting a frozen embryo transfer after 5 days of progesterone regardless. They had a 63% success rate, okay? In the group that did the ERA test, and it showed that there was not a receptive lining, they needed adjustment, but they went ahead and got the embryo transfer after 5 days of progesterone exposure anyways, they literally had the exact same success rate. What does that mean? It means the ERA test doesn't even detect if you are receptive or not. Forget whether it can predict helping you. It can't even predict if you're pre-receptive or receptive, because it's no different than the group that was receptive. In other words, it's a scam. It's completely, totally useless. And here's the kicker. When they looked at the group that adjusted the transfer based on the ERA results, they actually had a lower success rate. It was actually detrimental in that group to undergo the ERA test. So if you're adjusting based on your ERA, you are actually going to have a lower chance of success. So please, please, please stop doing it. So then, of course, everybody's saying, well, maybe it's the group you're choosing, right? Maybe it works only in the patients that have had recurrent implantation failures, or it's working in the patients who have had recurrent, miscarriages or something along those lines. Well, the reality is, if it can't even detect whether or not you are actually receptive or not, which it clearly can't from this very well done randomized controlled trial, then the reality is it can't detect it in any group. It's not going to be better in another group. And there's data in that group with the recurrent implantation failures that they actually have less endometrial receptivity window changes. They tend to be more receptive. In fact, there's a really brilliant theory that says they are actually too receptive and they're accepting bad embryos that a normal endometrium wouldn't accept. So they get pregnant, but then they miscarry. It's not because they're post-receptive, pre-receptive, and there's a problem that occurs subsequently. It's that they're actually hyper-receptive and accept any kind of embryo, even when that embryo really shouldn't be sticking because it's not strong enough or capable enough to continue. So based on this data, and I love these guys, God bless them for coming up with this study, no one should be doing the ERA. The ERA should be pulled off the market. It doesn't even detect what they claim it can detect, which is the endometrial receptivity. It's no better than having no result at all. It makes no difference. So for those of you who have done an ERA or are planning to do an ERA, stop. And I have to apologize to the people we did it for, because now looking at this, had I known all this stuff back then, it wasn't available. So I can claim a little bit of innocence there. But had I known all this stuff back then, I never would have used it. And I'm really proud of our team. for noticing all of this stuff years ago. We've been pounding the anti-ERA pulpit for quite some time. Tarek actually laughs anytime he hears the word ERA, but it's useless, guys. Do not do an ERA. It is completely useless. There is no benefit to a test which can't even do what it suggests it can do. Forget whether or not it's predictive of live birth. It can't even actually discriminate between receptive and non-receptive because there's no difference in the outcomes. So stop doing this test. It's useless. I hope you enjoyed that segment of Fertility Fact or Fiction. We have definitely tried as hard as we can to nail the coffin shut on the ERA test, although I'm sure I'll be doing this again in a couple of months when someone asks me about it.
Next week.
Next week, yeah.
Next week.
And we definitely strongly advise against doing that test. I will happily take questions now from everybody and look forward to your feedback on this. Let us know if you did the ERA and it did actually make a difference for you. Love to hear it. And likewise, if you did it and it didn't work for you, which is typically what I end up hearing about, let us know that as well. But useless test, totally unnecessary, not going to help you.
Hello, Dr. V&T.
Can I shut off?
Absolutely.
Absolutely. Okay. Far away. V&T.
Okay.
That's you and me.
Hope you're having a great week.
We're having a good week.
Someone recently mentioned about the fertility treatment using Invacel.
Yeah.
What is your thoughts on this? Thank you for all you do.
So Invacel is this transparent plastic egg where you put the sperm and the egg together and you stick it in the vagina and you let the embryo, which hopefully is forming in there, incubate in the vagina instead of in an incubator. So in theory, it's supposed to cost less. It does a little bit. And you can do IVF for less. The reality is it's not that much cheaper. If you need ICSI, it's definitely not that much cheaper. And I just find the whole idea crazy. Most importantly was that success rates were roughly equivalent to what you get from an IUI, a little bit better. And it was about, depending on where you're doing your IUI, it was anywhere from about 4 to, I should say probably 2.5 to like 5 times higher in price. So it didn't make any sense. I don't know of anyone that's continuing to do it, but I'm sure somebody somewhere is. If you want dirt cheap IVF, there are places that do dirt cheap IVF. I'm not a big proponent of it. I don't think it's a great idea. We are a very frequent location for refugees for one particular program in the US, which is very well known for cheap IVF, where patients have gone and had a terrible experience and an utter failure. And they're told, oh, well, don't worry, just do it again. We're only $5,000. So then they come to us looking for answers. And I realized like half the stuff that was done was just ridiculous. So yeah, don't try finding workarounds for cheap IVF. It's much better for you to save and go somewhere good, or, in Canada, use government funding rather than to go for something that's got a very low chance of success.
Hi, Dr. Victory. Regarding NAC for endo, do you recommend taking daily leading up to and past frozen embryo transfer? And when would you stop NAC?
Yeah, so we actually, for our patients, continue our NAC throughout the whole time. NAC is a good anti-inflammatory, and as far as I know, there's no downside in pregnancy. So we continue it in our patients. I don't love adjusting lots of stuff in pregnancy if I can avoid it, so we keep it going.
Why do you recommend 6 days of progesterone for day 6 embryos? And how about day 7s? Thank you so much, as always.
So we reviewed a study, which Tarek can put there, right there. So you should actually be able to find that one. You could probably put it up in the middle of the show. So it's on our YouTube website. It's called 6 or 7 day 6 or day 7, which we need to change to 5 or 6 days of progesterone. But essentially it showed that if you have a day 5 embryo and you put it in on day 5 or day 6, it made no difference in the outcome. But if you had a day 6 embryo and you put it in on day 5 or day 6, there was no difference in success, but there was a higher rate of miscarriage in the patients that only had 5 days of progesterone. Day 7s, no one knows what to do with day 7s. It's a very low success rate with day 7s. So I would only put them in after 6 days of proj, but there's no studies on that I'm aware of.
From Instagram.
I miss our buddy from, where was she from?
Oh,
Scandinavia or something like
yeah,
that.
that was a lot of
With
fun.
all the wild comments.
Yeah, that was fun.
Yeah, we got to get her back on.
Dearest V and T, how long after COVID do you recommend starting an FET? Are you aware of any evidence that impacts FET timing? Thank you for helping us educate ourselves.
So I always have advocated for 2 months because we know the immunological impact of COVID on your, your immune system. And so we have always said 2 months. However, the data actually doesn't support what I'm saying directly. In small studies which have been done, and they are small, they showed no difference in timing in relation to COVID. It doesn't make sense to me. That's why I can't support that. I do believe very strongly that there is likely a disadvantage to doing a embryo transfer when your immune system is inflamed. Having said that, the more recent strains of COVID are not nearly as aggressive as the original strains. Obviously, we're all aware of that. So maybe it's not going to have as much of an impact. It's kind of like having a cold, and I wouldn't tell you to wait 2 months after a cold. So you could probably try later on.
Hi, Dr. V&T. Why would a doctor recommend 10-day priming, which includes 10 days of androgen patch, estrase, and birth control? Yes, all 3. Are there any benefits to this priming protocol?
Do you want to answer that one?
Madness. Absolute madness is my conclusion.
Tarek had the compliment of his life from one of my patients who had the good fortune to meet my dear friend here, who told him that he could probably just replace me if I wasn't here. So,
but you're better looking, so
no, that's not true. So, that makes absolutely 0 sense to me. So, estrogen priming has been proven to be detrimental. There's a great Chinese study, randomized controlled trial. It cut the success rates for live birth in half. So that doesn't make any sense at all to me. I don't estrogen prime. Birth control priming, it's actually not a primer. It actually suppresses. Priming is designed to push your eggs or to line them up so they grow at the same time. Birth control pill will line them up, but the problem is it'll suppress them as well. So you'll end up with fewer eggs. And there are meta-analyses that show that. So that's a crazy protocol. Yeah, and I would run from fertility.
Absolutely
Even
run.
Tarek said he was going like this, right? So yeah, I would not be going to a fertility center that supported that. I mean, if they have evidence to support it, I'd love to see it, but it makes no sense, and I'd happily show them the evidence against it. It's on our YouTube channel.
Hi, Super Dr. V and Sidekick T.
Yeah, that's good.
That's good, yeah.
Yeah.
Transfer next cycle.
Okay.
What can I do until then to up my chances of a sticky embryo?
Well, I can't tell you because I don't know anything about you, so this is nice and generic, which keeps me out of trouble. Things you can do to improve your embryo transfer. So simple things: eat healthy, low sugar, low carbs. Number 2, exercise. Exercise improves your chances of success. In particular, if your weight is over the ideal or under the ideal, get your weight closer to the ideal. So either eat a little if you need to bring up your weight, or eat less and exercise more if you need to bring down your weight. In terms of vitamins, melatonin, vitamin D, fish oils have all been proven, as well as, of course, the prenatal vitamin, all helpful and can improve your outcomes. Stay as calm as humanly possible. So meditation, prayer, support groups, coaches. We work with a couple of coaches who we love very much. So you can work with them, family, anyone you want to work with that will help you stay calm and relaxed. All of these things will be beneficial for you. The Mediterranean diet has been shown to be beneficial, so we do tell people to, stick to that diet. If acupuncture relaxes you, it can be beneficial. If not, don't do it. It's probably either harmful or useless. So those are the kind of low-key things. And then probably the most important one, if you are in a heterosexual relationship, exposure to ejaculate primes the lining of your uterus to increase the chances of an embryo sticking. So have a lot of sex leading up to your embryo transfer. And it's also really good for reduced stress.
Dr. V&T, hello. If I start with endometrium and switch to prometrium when I run out during the FET and pregnancy, will it be a problem? I'd like to switch to prometrium since it's a lot cheaper.
Yeah, not a problem at all. Fire away. There's zero risk in switching from any of the progesterones to any other, as long as you're talking about the vaginal suppositories. There is a difference with progesterone in oil and stopping that and going to the vaginal, but there is no difference between any of the vaginal formulations.
My doc says, figure you like this one.
Oh boy, here we go.
My doc says letrozole protocol does not add any benefits. She continues.
Yeah.
He prefers a modified natural cycle. Would you say that's my best bet if I have endo? My clinic does not treat nor investigate it. Continue. My doc also added PIO injections into the natural modified cycle. What are your thoughts, Dr. Victor?
Well, the letrozole protocol has been shown in a specific study that compared natural hormone replacement and letrozole cycles to be better. And so I disagree with your doctor. It is probably, and I say probably because I don't have any evidence for this, but physiologically it would make a lot of sense that it'll give you the best approach if you have endo. And a clinic that doesn't investigate for endo is another runner. So I gotta say, like, I heard a lot of stuff.
We should make an animation for a runner scenario.
Yeah. Women like running and screaming.
Yeah.
You're right. We can hit a button.
Yeah, and then some guy just runs.
Some guy runs. I like that. You got it.
Yeah, I'll
work
do
on that. So listen, I heard a ton of people saying stuff about all the different clinics they were at the show I was at recently. And some of it was a bit mind-boggling. So if your clinic is not investigating you for endo, your clinic is not interested in your success, because we know that endo reduces your chances of success. Now, does everybody need surgery? No. But is there evidence supporting the idea that patients with endo do better with specific protocols, supplements, suppression therapy, surgery? Yes. So you can't just ignore that and say we don't do it. I mean, you can, but that's not good medicine. That's cookie cutter. And like we always say here, we're not making cookies, we're making babies. So make sure that you guys are getting good care. And I hate that you have to advocate for yourselves. I'm definitely opposed to that. You shouldn't have to advocate for yourselves, but it's very clear that sometimes you do. So, yeah, I would not be going back to a clinic that said, I don't investigate for endo. That doesn't make sense to me. And I mean, there are studies out there, we've reviewed them on our show multiple times, showing letrozole is better. So show them that study and say, how can you say the natural is the same? It isn't.
Dr. V, thank you for everything you do.
You're welcome.
What do you recommend? Is it important to prepare the body before an embryo transfer? What do you recommend doing to prepare for the embryo transfer?
I think we talked about that one.
Yeah.
I got to tell you, we have Izzy on with us from Taiwan.
Oh,
that's a new one, man.
Taiwan.
Hi, Izzy. Thank you for joining us. That's really sweet of you, all the way from Taiwan. That's awesome. What's fertility like in Taiwan? Izzy, tell us. We also have Jesus is the Only Way joined us too. That is a name. I like that.
Welcome to the show.
I like that. I'm spiritual and religious, so hello.
Hey T, Dr. V.
So is it directed at you or me? It could go either way.
I would not feel comfortable answering this one.
All right, fire away.
FSH 6.7. AMH 0.709.
Nanograms or picomoles?
undeclared.
Okay.
Age 35.
Okay.
Please answer! Exclamation mark, exclamation mark, exclamation mark.
Okay.
Should I do IUI or straight to IVF?
Oh.
Hysteroscopy to remove polyps, then I make my decision. Hand pink waving, hand pink waving, hand pink waving, hand pink waving. So it's like over here, you know? Like, please pick me, you
Pick
people
me,
that
pick
never
me.
pick me. Yeah.
Okay, so I can't answer that question directly because I need to know way more information about you. It sounds as though if that's your nanograms per mil for your AMH, that it's on the lower side. So you need to have a lengthy talk with your doctor about the risks and benefits. I can definitely talk about risks and benefits. So the advantages of IUI, it's cheaper, it's definitely less invasive, it's very easy to do, and it has a modest success rate. How high? 10 to 15% with pills, 20 to 25% in good experienced hands with shots. So that's what you're going to get if you go down the IUI route. What are you going to get what's the disadvantage? Lower success rates, and you may eat up some valuable time trying it several times before you actually get to IVF if you decide to go down the IVF route. That's the only disadvantage. The other minor disadvantage, you have no control over how many babies you get pregnant with. Typically, we're all pretty careful now, so maximum twins, but we do still occasionally get a higher number of babies inside when we do IUI. So you do need to be prepared for that. If you're going to IVF, the advantage, it's a laundry list. Number one, way more control. Number two, you can check your embryos, make sure they're genetically normal before you put them in. Number three, way higher success rates if you're with a good program. Number four, fertility preservation. So you make your embryos now, you get pregnant, you come back 2 years later, if you still have a good embryo, you're still dealing with your 35-year-old embryo instead of your 37-year-old embryo. So there's a whole bunch of potential benefits and many more. The disadvantage, it's more invasive and it costs more. So those are the two significant disadvantages. But overall, way higher success rate, way more control, and you're doing that fertility preservation, which you don't get with the IUI. So you have to talk about how that fits for you with your physician so they can tell you what they think, and then you have to make a decision that's right for you, because what we think isn't necessarily what's right for you.
Hi, team. Dr. V, do you find that DQ alpha matches impact success in IVF?
I'm still trying to figure that out, to be honest with you. So there is no question that there are studies that show that it does. There are actually studies that show that it doesn't. And there's other studies that show that other DQ mismatches like Bravo are the problem, not alpha. Nobody knows for sure. We do pay attention to it because it shows up on our Fertility testing. I should probably ask Fertility to tell us what percentage of patients have before and after and have gotten pregnant. So I don't know yet. I really don't. It's a great question. We just don't have the answers.
What should progesterone levels be for endo patients at FET?
According to the study we reviewed about, 3 months ago? 2 months ago?
Yeah, I think so.
2 or 3 months ago, in US units, 45, in Canadian units, 150.
Hello, Dr. VNT. What is the best time of cycle to get your AMH tested? Thanks.
AMH is cycle independent. You can test at any point in time. That's the beauty of AMH. It doesn't matter when in your cycle you test. I'm starting to question that personally, but I don't. So far, the studies have not shown a difference.
What studies can you share with us
Oh boy.
about when to do uterine PRP before a frozen embryo transfer?
We have a video on uterine PRP, don't we? We have a PRP video on our YouTube channel. Yeah, we have a PRP video. So I mean, if your lining is thin or if you have unexplained failures, there are many studies which show that it is beneficial. I don't have a way of showing them to you right now, but we have many. I wonder if one of them is in here. But if you go to PubMed and you type in PRP and frozen embryo transfer, you'll actually see a bunch of different studies. Yeah, see, I don't have it labeled properly in my thing here. I wish I did. That's a shame. I got lots on letrozole and FET though. Yeah, I don't have the PRP ones.
I haven't shared our videos on PRP right above you.
Do you? There you go. So they're all up here, and just click on those and watch those videos, and it'll tell you when it's good and how it's good. But one study showed a 50% increase in success if you had unexplained failures before. So check those out. Yeah. I'm gonna have to hook this up to our Dropbox because then I'll have access. I don't know how to do that.
How can I bring this up with my doctor? Did ERA in April, going for my transfer in a few weeks.
Don't follow your ERA. It clearly decreases your success rates. It is useless. It is completely useless. Do not follow the ERA. Tell your doctor to look at that new articles in Human Reproduction. It's in the in press section because I always read ahead. It's not even out yet, but everyone with access to human reproduction can find it. And Lord knows if your doctor doesn't have access to human reproduction, that's a whole other level of question you need to ask. But it doesn't work. Ask them to, review the JAMA study. Explain to you how they can question that. The JAMA study, which I showed you first with Doyle, shows that it doesn't work. Just went for my 3rd frozen embryo transfer on Mother's Day. Wish me luck. I wish you luck. That's from TikTok. Does our clinic do intrauterine PRP? Our clinic now does every kind of PRP, intrauterine and intraovarian. If you had endo, had excision, and have failed FETs, are those unexplained implantation failures? No, it depends on what kind of protocol they used for you. So some people go for endo treatment and then end up with an estrogen protocol, and that just turns the endo back on, and that's a waste of time. So it all depends on many different factors and how they treated you. Yeah.
When, after how many hours do you typically transfer a 5 or 6 or 7 day embryo? When is the right time for FET?
So for us, a day 5 is after 5 days, a day 6 is after 6 days. We don't do a lot of day 7s, but a day 7 would be after 6 days.
My last ERA, showed I was late receptive by 12 hours.
Okay.
Should I ignore that info going into my FET coming up?
Yes.
Had a failed transfer in January.
It's useless. There may be other reasons for why you're failing. I'm not questioning that. But the ERA is not going to help you. Randomized controlled trial, hundreds of patients, unequivocal data. The group that didn't use the ERA but had it done had absolutely no difference between the ones that were receptive and the ones that were not receptive. That means it doesn't work. It doesn't even detect whether or not you're receptive. And I mean, the author of that new study has got to be like just sheer genius. I got to call them and say, you are the bomb. It doesn't work. It's useless. It's a completely useless test. It's a fraud. It should be pulled off the market immediately. And if the people at iGenomics are honest, they will pull it off the market.
How do you really feel about the ERA test?
Although I think they sold it is what I heard. So I don't know.
After Oralissa,
Yeah.
do you need to wait for a period then start modified FET cycle, or can you skip waiting for period and start FET cycle?
You can skip waiting. We go straight off of Lupron and letrozole. Just stay on letrozole an extra few days, and then we watch the lining grow. It works fine. Oralissa's even less suppressive, so yeah, you could do that.
Have you ever transferred a day 3 with a blast in the same cycle?
Once. So there is actually, and I love that question, there is actually an Israeli study where they looked at doing a day 3 and a day 5 in the same cycle, and they actually showed that it increased the success rates. So we tried it once, and that girl actually did get pregnant. But it's super risky because you could knock off the first embryo when you put in the second. So you have to have kind of a longer uterus, and you got to know exactly where you put the first one, and then not go past it when you're putting in the second one.
Have you ever transferred a day 3 with a blast in the same cycle?
You just asked me that.
Oh, sorry. How much progesterone do you want to see for an endo patient during an FET?
45 nanograms per mil or 150 nanomoles per liter.
What fertility test should be done ahead of an FET? Can I schedule a consult with you to review the results? My doc doesn't even believe in tests from fertility.
I'm a huge believer in fertility tests. I love fertility. Yeah. So yes, you can schedule a consult with me. Just go to info@drvictory.com and ask for a consult. We do it all the time. And then, which tests? So if you're my patient, you tell them you want the Victory combo, and they give you a discount, and it's a combination of their microbiome test and their immune test, and they batched kind of all the important immune ones together. And then there's 2 combos. There's one for people with recurrent pregnancy loss, and then there's another one for people that have had failures. So we normally are just doing the failure ones, and it's great tests. And then yes, of course, we can interpret it for you and tell you what you need to do, for sure. Fertility will do that for you too. Like, you don't necessarily need me. You do the test. Dr. Panagiatis Veneriatis will actually jump on a call with you, a Zoom with you, and tell you what you should do. He's a cool guy. I like him a lot.
I see some studies that say 5 versus 6 embryos are the same, and then I see others where day 5 has better implantation rates. Which one?
We reviewed that on our show a couple months ago too. So you have to have a huge change in blastocyst quality for the day 6 to not have the same success rates as the day 5. So if you've got a weak day 6 compared to a good day 5, yes, your day 5 is going to do better. But a good day 5 compared to a good day 6, it's a negligible difference in success.
Thoughts on prednisone and preterm birth history?
I'm not sure I understand the question. Does prednisone prevent preterm birth? No, not that I'm aware of. But that question needs more question.
Here's one on Emma and Alice.
Oh God.
Would the Emma Alice be the same?
I have no poker face. It's like a huge problem.
Also, just sent my samples to Greece to Fertility based on one of your posts.
Okay.
I have adenomyosis, so I'm worried about my microbiome at this point.
Adenomyosis needs Lupron and Letrozole. It has nothing to do with your microbiome. But your microbiome could be distorted, and Fertility will tell you that. Is Emma and Alice the same? No. Emma and Alice doesn't have the full depth and breadth of what Fertility offers, and they don't categorize it in a way that makes it easy to understand which antibiotics you need. So I don't use Emma and Alice, but that's me.
Here's a question I know you'll love.
Okay.
Good evening, gentlemen.
Good evening, gentlemen. Hey, I like that. That's a good start.
Do you offer lit at your clinic?
We do.
There you go.
Yeah.
Nice and easy.
And if you're not here, my very good friend, Dr. Fred Zaneku, does it in Toronto at Tripod, so you could do it there.
Can having a past C-section cause issues when implantation or conceiving in the future?
Can having a past C-section? If you get an isthmocele, which is that cesarean scar defect, looks like a shark's fin, yes. Otherwise, generally speaking, no.
Is it worth it to have the testing done as a couple to see if they are carriers for balance translocation, if they have no intention of doing embryo adoption or IVF with genetic embryo testing?
What? Say that again?
Okay.
That made no sense
Ready?
to me at all. Yeah, I'm ready. Is it worth it?
Is it worth it
Yeah.
to have the testing done
Yeah.
as a couple to see if they are carriers for balanced translocation,
Okay.
if they have no intention of doing an embryo adoption or IVF with genetic embryo testing?
Oh, okay. So basically, if you're not going to test the embryos, what's the benefit of getting yourself tested because you're not going to know if the embryo is a problem or not. Yes, it would be valuable only in the sense that you would know what to expect. If you have a balanced translocation or an unbalanced translocation, you may have a much higher rate of miscarriage. So yes, in those circumstances, it would make sense to do that. Yeah, but only so that you can alter your expectations. It's not going to change what you do if you're not planning to selectively not use the abnormal embryos. Keep in mind that if you do have a translocation that's significant, you could end up with embryos that are not compatible with life. So deselecting those embryos is not taking away the ones that are like you, where you've obviously grown up to be normal. They're deselecting the ones that don't have the opportunity to grow up to be normal. And the geneticists can actually predict that. So that's what it's used for.
Can there be issues with the functionality of the fallopian tube, even if they are shown to be open during the HSG?
Yes. So your tube can be open, kind of dangling over here. I don't know how much of me is on the screen here, but if your tube is over here and your ovary's way down here and the tube can't grab it, it can be open but stuck in a position where it's not functional. So yeah, you can have an open tube that is not functional. Definitely.
Sounds like something you would have enjoyed drawing.
I would have. I should have. Yeah, sorry.
How can a clinic test for endometriosis?
You can't. There's only one test for endometriosis: surgery. There's no other valid test. I saw the Receptiva DX thing, which says it's got a 93% sensitivity and like a 97% specificity. It doesn't detect endometriosis. There's like 2 studies that show that it didn't help. So there's no test for detecting endo. 0. There's no test. You got to operate.
Can you link the letrozole FET endometriosis study?
We'd have to look for it. It's the Lupron and letrozole for unexplained failures.
Lupron and letrozole?
Yeah. But I don't know if we have it.
Is it letrozole and frozen embryo transfer? That one?
No, it's Lupron and letrozole prior to. I'd have to go looking for it.
Okay. We'll leave that for now.
I know I found it before. Oh, I can't do it now because
you can.
Linked. Yeah,
Don't touch.
Don't touch.
Yeah. Hi, Dr. V&T.
That's us.
If one miscarried before fertility treatment, then first failed euploid transfer, what would your next steps be?
If one failed transfer and then miscarriage after a euploid transfer, I need a consult with you to figure that out. I can't answer questions like that because it's too non-specific. I need to know all the details about you. That kind of history, we would definitely want to do a lot of testing, for sure. Yeah.
Is that something on there or is that nothing?
Can you detect an ismacele from a saline sonogram? All the time. That's Patty on TikTok. Patty, I detect ismaceles on SISs nonstop. All the time I do that. So yes, we can.
Hi, Dr. T and Dr. V.
That's us.
Yeah, you better believe that's us. Will you share a link?
Thank you for stroking his ego.
Will you share a link to this recording? Of course.
Yeah, of course. Yep.
They're always on our YouTube channel.
Yeah, they are always on our. He's right. They are always on our YouTube channel.
They are always on our YouTube channel.
They're what? It takes about a week.
Yeah, and so the lives are up right away. So if you do a live and you go in our live segment, they're always there.
It's always there.
Those are always there, and then they get edited and reformatted to be pretty and palatable for short.
And
short
they're
video.
up on Instagram and.
Instagram takes them away.
Oh, do they?
Instagram takes them away.
Facebook keeps it for 24 hours.
No, Facebook keeps it for life.
Oh, does it?
Yeah.
So
Facebook,
these all stay there?
These stay there.
Oh, I never knew.
Yeah, these stay
I don't
here.
go on Facebook.
Yeah. Hi, T and Dr. V.
Yep.
I assume that's the voice of the Haya.
Yeah.
What are your thoughts on the Dutch test?
Don't believe in it.
There you go.
Yeah. No proof again.
Hi. Chemical pregnancy after FET What could have been the cause of it not working?
Genetics abnormality, problem with your lining, uterine microbiome, either absent good bacteria or present bad bacteria, hormonal problems, thyroid problems, possibly very controversial, sperm quality issues, sperm DNA fragmentation, bad luck, a million different things, embryo quality, embryo energy efficiency, vitamin levels.
Is it normal for a patient with endometriosis to go 2 rounds of IVF and no embryo created? First round was a normal IVF. Second time was ICSI. Both rounds we retrieved 5 eggs in each cycle, but no embryo.
That's dependent on your lab. So some labs do a better job than others, and it depends on where you went and how they stimulated you and what they used in your stim, and how high your hormone levels were, and how aggressive the stimulation was, and did they use priming, did they not use priming, were you on suppression beforehand, after, like there's a lot that goes into it. And it depends on the lab technique. Did they activate your oocytes? Did they use the Neupogen in the culture media? Like there's lots of different things that can go into improving your chances. So
what is your opinion on using 3-day frozen embryos untested for older couple?
Look, if it's your only option, it's a reasonable option, but virtually everyone will tell you to go to day 5 and then get your embryos tested if you're older, because we don't know if they're normal or not.
Are genetics infusions covered?
Genetics infusions? There is no such thing as a genetics infusion. Genetic testing is covered in Canada, but it takes forever right now to get a result.
What if you transfer a day 5 embryo with a day 6 embryo? What day is ideal to transfer? A lot of day
6.
questions.
Wait, I got one here.
Okay.
From Manda. Does a cycle induced with Provera typically lead to a normal cycle? Will the hormones be the same as if it was a natural cycle? No. Because when you're inducing a cycle with Provera, you are not causing an egg to grow. You're just causing the lining of your uterus to shed. No egg growth occurs. So you're just waiting for the next irregular cycle, or you're waiting to take another blast of Provera. So Provera does not cause an egg to grow. It merely causes you to start and stop a period. That's it. Great question. Is it a busy night or is it a quiet?
That's good.
Night?
You're good.
Well, no, we're done.
Oh, okay.
How far do you want to go?
I think you can wrap this up in
Quickly?
in 5 minutes.
All right.
I believe in you.
All right. You're not going to sing I Believe I Can Fly.
No. My voice isn't tuned today.
All right.
Hi.
Hi.
Does a KIRAA genotype without a mismatch between mom and dad affect IVF success?
Again, it depends on who you believe, but if you are talking to the guys at Fertility, they believe yes. If you talk to a reproductive immunologist, they'll also probably say yes. I'm not 100% convinced yet, but they seem to have enough data to support what they're saying. So it probably does have a little bit, but it's usually only a problem if you both have it, not if just one of you has it.
After taking Orilissa and Lupron for 3 months, after stopping Orilissa, do I stop letrozole? Doing letrozole instead of my FET, or just stay on it? And then she asked a follow-up question. Thoughts on taking Chinese herbs while on Orilissa? A lot of Orilissa here.
So we would extend your letrozole for 5 days past the Orilissa, and that should allow your lining to start growing, which is what we do. Chinese herbs, yeah, I'm a believer in traditional Chinese medicine. Mary Wong, who we've had on the show before, was literally across from me at the Canadian Fertility Show, her booth. So she's great. I love her. And she wants to come back on the show.
Oh, that's great.
Yeah, so maybe reach out to Mary and have her back.
How do you know if adenomyosis on my previous C-section report states bogey uterus? And I heard this can be caused by adenomyosis. Would this be a concern?
So it's boggy uterus. And boggy at the time of C-section is meaningless because that just means your uterus wouldn't contract. It has nothing to do with adenomyosis. You can't detect adenomyosis in a C-section. It would be impossible.
I only have a couple embryos after many retrievals.
Okay.
Before first FET, should I be asking for any extra testing? No history of loss.
Yeah, you know what? I plagued myself with that exact question. It depends on a lot of factors. Your age, how difficult it was for you to make your embryos. Are they genetically normal? What's your family history like? Can you afford to do it again? I mean, there's a lot that goes into it. So those are the factors you should consider, but I can't tell you what to do. I just tell you what to think about, and then talk to your RE or talk to us and I'll give you advice, but that has to be a consult.
2 questions left.
2 questions left. That's pretty good.
Okay.
All right. People are joining now on TikTok.
They don't stop joining.
That's wild. Yeah. They come and they go. Hi, TikTokers. Yeah.
Fresh transfer for RIF.
No. The polar opposite. Your RIF chances, recurrent implantation failure chances, are probably higher with a fresh transfer than they are with a frozen. So I wouldn't.
Last question.
Last question.
Both mom and dad went for a DNA test.
Okay.
The result of both chromosomes are fine.
Okay.
Wonder, is it still a need to do a PGTA on the embryo?
So the fact that your genetics are normal has nothing to do with the chances that your embryo is abnormal or normal. That's mainly determined by a woman's age and a little bit by the man's age. So even if both parents are genetically normal, when you're 35, depending on which study you read, you have roughly a 50% chance your embryo is abnormal. So in other words, if you make 10 embryos, 5 of them are not going to be normal, 5 of them will be normal. By the time you're 38, that's like 2/3 to 3/4. And by the time you're over 40, you're looking upwards of 80%. So it has nothing to do with you being genetically normal. It has everything to do with the age of the woman and to some extent the age of the man.
One just floated in. Can we give her a chance?
One more, sure. A floater.
Yeah, just popped in.
Floater.
What is your opinion
Yeah.
on 3-day embryos self-correcting? My doc saying they do.
They do. That's true. Genetically abnormal embryos have been proven to self-correct. There is evidence of that, and they do it probably around day 3, maybe a little bit later. But we don't know how that works or how consistent it is. And remember that we are doing genetic testing not on day 3 embryos, but on day 5 embryos. Day 5 embryos probably do not correct very often because in a study by David Barad and his group, they showed that even if you transfer known abnormal blastocysts, 1 out of 140, was it 2 or 146, ended up implanting. So you have a 0.7% chance it's going to be normal. Done? Awesome. We finished all your questions. All right, guys. Have a great night. I hope you have a wonderful long weekend. Memorial Day for the folks from the south of us, and for the Canadians, it is the May 2-4 long weekend. I hope you guys have a wonderful long weekend. Enjoy and be safe, and please don't drink. And we will see you again next week, next Tuesday, right?
Mm-hmm.
Yeah. Next Tuesday on Fertility Fact or Fiction. Look forward to having you there. Have a great night, guys.